Welcome to MRCPology channel for quick review, understanding of the topics, and a stepwise approach to the PACES exam. Wasting of the hand muscles means loss of the normal bulk of the intrinsic hand muscles. It usually results from chronic lower motor neuron denervation, prolonged disuse, or less commonly, primary muscle disease. In PACES, focal hand muscle wasting should immediately make you consider a lower motor neuron lesion involving a peripheral nerve, nerve root, brachial plexus, or anterior horn cell. To understand the pattern of wasting, first revise the important muscles of the hand. The lumbricals flex the fingers at the metacarpophalangeal joints while helping to extend the interphalangeal joints. The lateral two lumbricals are supplied by the median nerve, while the medial two are supplied by the ulnar nerve. The interosseis abduct and adduct the fingers. The dorsal interosseis abduct and the palmar interosseis adduct. These muscles are supplied by the ulnar nerve. The median innervated intrinsic muscles are remembered by the mnemonic LOAF. These are the lateral two lumbricals, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. They are particularly important for thumb opposition and abduction. The hypothenar muscles control movements of the little finger and are supplied mainly by the ulnar nerve. The long finger flexors arise in the forearm. Flexor digitorum superficialis is supplied by the median nerve. The lateral half of flexor digitorum profundus is supplied by the anterior interosseous branch of the median nerve, while its medial half is supplied by the ulnar nerve. The long extensors also arise in the forearm and are supplied by the radial nerve, mainly through its posterior interosseous branch. The radial nerve does not supply the intrinsic muscles of the hand. When considering the nerve supply, think from the medial side towards the lateral side. The ulnar nerve mainly supplies the medial side of the hand and most intrinsic hand muscles. The median nerve supplies the thenar muscles and sensation over the lateral palm and lateral 3.5 digits. The radial nerve supplies sensation over the dorsolateral hand and powers the wrist and finger extensors through muscles located in the forearm. The usual mechanism of wasting is simple. Lower motor neuron injury leads to reduced motor unit activation. This causes denervation of the muscle fibers. Persistent denervation then produces atrophy and visible loss of muscle bulk. The wasting is often most obvious in the small muscles supplied by the ulnar and median nerves. The distribution of wasting helps localize the lesion. In an ulnar nerve lesion, look for wasting of the first dorsal interosseous muscle, guttering between the metacarpals, and loss of hypothenar bulk. Finger abduction and adduction will be weak. A more advanced lesion may produce clawing of the ring and little fingers. In a median nerve lesion, wasting is most obvious over the thenar eminence. Thumb abduction and opposition are weak. Severe thenar wasting may produce a flattened appearance of the thumb base. A C8 or T1 radiculopathy or a lower brachial plexus lesion may cause more diffuse wasting of the intrinsic hand muscles. Radiculopathy may be associated with neck pain radiating into the arm. A plexus lesion may be associated with shoulder or arm pain and a broader pattern of weakness or sensory loss. In motor neuron disease, wasting may be asymmetric and accompanied by fasciculations and progressive weakness. Sensation remains normal. Look elsewhere for upper motor neuron signs because the combination of lower and upper motor neuron findings strongly supports the diagnosis. Syringomyelia may produce lower motor neuron wasting of the hand muscles by damaging the anterior horn cells in the cervical spinal cord. It classically causes dissociated sensory loss with impaired pain and temperature sensation, but preserved light touch and joint position sense. Disuse, cachexia, and myopathy usually cause more generalized wasting. The pattern is less likely to follow the territory of a single nerve or nerve root. Myopathy usually causes proximal rather than isolated intrinsic hand weakness. During examination, concentrate on the distribution. Thenar wasting suggests a median nerve lesion, a C8 or T1 lesion, or motor neuron disease. Hypothenar and interosseous wasting suggest an ulnar nerve lesion, a C8 or T1 lesion, or motor neuron disease. Diffuse asymmetric wasting with fasciculation suggests anterior horn cell disease. Wasting accompanied by sensory loss makes a peripheral nerve, nerve root, or brachial plexus lesion more likely. Wasting without sensory loss should raise concern for motor neuron disease, another anterior horn cell disorder, or a pure motor neuropathy. In this patient, there is visible wasting of the hand muscles, but no clawing or other obvious deformity associated with a severe ulnar lower motor neuron lesion. The absence of clawing does not exclude an ulnar lesion. It may indicate an early lesion, incomplete weakness, or a lesion at a different anatomical level. The finding must therefore be interpreted with power, reflexes, sensation, and the remainder of the neurological examination. To determine the cause, assess the pattern of weakness carefully. Examine tone and reflexes. Map sensory loss. Look for fasciculations and search for upper motor neuron signs. Perform appropriate provocative tests for median and ulnar nerve entrapment, such as Tinel's and Phelan's tests for carpal tunnel syndrome, and assessment around the cubital tunnel for ulnar neuropathy. Nerve conduction studies and electromyography help localize the lesion to the peripheral nerve root, plexus, or anterior horn cell. They can also demonstrate active or chronic denervation and help distinguish a neurogenic disorder from a primary myopathy. Treatment depends on the cause. Entrapment neuropathy may require activity modification, splinting, treatment of contributing factors, or surgical decompression. Radiculopathy and brachial plexopathy require management according to the underlying structural or inflammatory cause. Progressive wasting, fasciculations, bulbar symptoms, respiratory symptoms, or associated upper motor neuron signs require urgent neurological assessment. A suitable PACES summary would be: there is wasting of the intrinsic muscles of the hand consistent with a chronic lower motor neuron process. I would further localize the lesion by assessing the distribution of weakness, reflexes, sensation, fasciculations, and any associated upper motor neuron signs. Remember the clinical sequence. Identify the wasted muscle group, match it to the nerve, decide whether sensation is involved, and then localize the lesion to the nerve, root, plexus, or anterior horn cell. Do subscribe to the channel for further videos.